Okay, good morning. I'm Celeste Clark, the director of the Raymond Coalition for Youth. I know a lot of you, but we might have some new people joining the call this morning. And our speaker is going to be joining us. We'll introduce her when she gets started. If you want to put your name and your organization in the chat box, please. So if anybody wants to get in touch with you or have an idea of who's part of the meeting this morning, that would be great. Let's see if I can share my screen and make this work. On our website is the Zoom, the agenda. That's what I'm trying to say. If anybody is interested in seeing the agenda, if I can get to it with the Zoom thing in the way. So here it is right here. We're going to go over some of our marijuana prevention warrant articles, and then we have Astrid as our speaker, and then we're going to be talking about the strategic prevention framework. Again, this is on rcfy.org underneath programs and then meetings, if you're interested in following along on there. So the first thing that we have is obviously we typically do introductions and welcomes, but via Zoom, that's not so easy. So that's why I asked you to put it in the chat box if you can. And we'll get started by going over, does anybody have any announcements they want to share with the group? You can raise your hand or just share it with us. No? Okay. So we have, Christine's been working with our youth action students, and the coalition's been talking about marijuana prevention, obviously, for many years, and been looking at doing a warrant article to go on our town ballot for the voters to vote on. Some of you know marijuana in the state of New Hampshire. We have therapeutic cannabis for people who need it for medical reasons. It's been decriminalized, so that is now similar to a traffic violation if somebody gets caught with marijuana, personal amount of marijuana. And the state has obviously been looking to legalize it. It's been a big effort by big tobacco, big marijuana, we call it the marijuana industry. So this is an effort to get out in front of that and to protect Raymond, I guess is the good way of putting it, the way that our children, our youth action members put it. They want to protect the community that they live in. So we have 2 warrant articles that are going before the voters. Again, I'll try to share it. The first one is warrant article 36, and it's to restrict any commercial signs promoting cannabis or marijuana or drug-related paraphernalia or products. And this is in, this was suggested to us to put this on. This was not even something that we had on our radar. And somebody mentioned that we should put that, there's a CBD store, I guess it would be, over in Epping that has a marijuana leaf promoting it. And that was brought to our attention that somebody didn't really want that in our community, which made sense to bring it to the coalition. We brought it to the youth action members. And so if a business was to open like that, selling any kinds of products, CBD or whatever, they would not be allowed to use a marijuana leaf to promote it, is basically what that warrant article is for. The second one is to restrict the commercialization of marijuana and marijuana-based products, which just I have the entire language here. And Christine, feel free to pump it, add anything, but it's, shall the town of Raymond vote to amend the zoning ordinance to restrict activities related to marijuana and marijuana-based products. This would include commercial marijuana cultivation, marijuana testing facilities, marijuana product manufacturing, marijuana retailers, on-site marijuana consumption at a business location, and any other marijuana-related activity for commercial purposes by which name is used. The warrant article is not intended to limit a private citizen's access to medical marijuana-related products in a private non-commercial residence. We also added that it's not pertaining to CBD products. And those were things that were brought up by our young people that were very important to them. Some of them have family members who use therapeutic cannabis, and that was important for them to have that piece in there. So those are going on the ballot. They are on the ballot for March. I don't know if anybody has any questions, or again, if Christine wants to add anything from the youth action members.
I'll just add quickly that we had a great conversation at the high school level yesterday about them, especially the Article 37. The kids understood that we want to protect the rural community of Raymond, but they also knew that if someone was really interested in getting a marijuana product, they could go to Candia, they could take a bike, ride their bike to Epping, they could, you know, they could go elsewhere, but they still were very much passionate about keeping Raymond free from signage, free from marijuana products in the town. So that was really good. It was a great conversation yesterday that we had to cut short because of school, but that's okay. It was a great conversation to have.
Again, this is completely a proactive
Yes.
measure. So if something is if it is legalized in the state of New Hampshire, our town selectmen have this information if they're making any decisions. The planning board will have this information as to where a location like this would go if it was to go into our community. So just completely prevention related when we're doing this work. Any other comments or questions? No? Okay. I'm excited. Carrie, I don't know if you want to introduce our speaker since you found her. She's Astrid Findon, and I want to make sure I pronounce it correctly, Henry from Lamprey Healthcare. Carrie Coulgian, who works at Lamprey, obviously, is a member of the board of directors, and asked if Astrid could come and talk to us about medication-assisted therapy or treatment. And with that, I will introduce Astrid. I'm not sure. And you need to share your screen, correct?
Yeah, thank you for the introduction. And
Absolutely.
like you said, I am the behavioral health manager and a behavioral health clinician here at Lamprey. I'm a licensed drug and alcohol counselor and also a licensed clinical mental health counselor. And first of all, I want to thank you for the opportunity to speak to you all about our medication-assisted treatment program. Just seeing who's attending this meeting, I can imagine that most people probably have some sort of familiarity with it. So I hope it won't be too boring. Feel free to chime in to ask questions at any time because I want to make this as interactive as possible. So let me just share my screen here. Okay, it should work. Okay. All right. So, like you said, I am going to talk a little bit about the medication-assisted treatment that we provide at Lamprey Healthcare, but also I want to talk more about addiction in general and what medication-assisted treatment is and how it can help people with an addictive disorder. Most of you probably know Lamprey Healthcare. I'm not going to go into much detail. Lamprey Healthcare is a community health center. We were founded in 1971, and we were the first community health center in New Hampshire. We have 3 locations, one in Raymond, one in Newmarket, and one in Nashua. The mission of Lamprey Healthcare is to provide high-quality primary medical care and health-related services with an emphasis on prevention and lifestyle management to all individuals regardless of ability to pay. So what that means is that we are primarily a primary care office, but in addition to the primary care services that doctors provide, we have all kinds of other programs to help the person, to support people to live a healthy life. That includes like prenatal programs, diabetes education, we have care coordinators, we have community health workers, we have a hepatitis C treatment program, and also a medication-assisted treatment program. And there's probably several other ones that I'm not even mentioning right now that I'm forgetting. So our goal really is like to not only care for the immediate medical needs for people, but really look at the broader spectrum of what it takes to have a person become healthy. Let's talk about the problem that deserves our attention, besides from COVID. This obviously started way before COVID was a problem. As you can see on this graph here, the opioid-related overdose death in New Hampshire spiked tremendously since approximately like 2014. This was a problem for a while. This is a problem that is a nationwide problem, but unfortunately, especially in New Hampshire, this problem has become really severe in the last few years. I know this graph ends in 2016. This is a graph from CDC. I haven't really found an updated one. We do have updated numbers, which it is not as spiking as much as it has been, mainly because we have implemented programs like MAT, but it is still a problem that will not go away anytime soon. Oops. This one is the next one. This is another graph that kind of shows more how this problem came, or it kind of can give a little bit of an explanation about this. If we look at these three different graphs, it shows the overdose death related to what substance it was. The blue one is prescription opioids, the orange one is heroin, and then the yellow one is the synthetic opioids like fentanyl or carfentanil. And as we can see, the death really rose when those synthetic opioids came onto the market and came into New Hampshire. The problem with the synthetic opioids is that they are much more potent and much stronger than, for example, heroin. When people buy a substance off the street, let's say they think they buy heroin, the problem is that oftentimes they're not, right now we know there's almost never heroin in it. They buy fentanyl or sometimes even carfentanil or any other laced substances, which are much more potent. The people are using the same amount that they have used before, but because it's so much more potent, they overdose and may die if they have, if they do that. The prescription opioids, actually, that rate is going down. It used to be a bigger problem in the early 2000s. In the 1990s, doctors were very, there was a lot of prescription opioids out there. Doctors would prescribe opioids a lot more than they do today, just because it's more regulated and restricted today, because we know the dangers of becoming addicted to them, and then also the dangerousness of turning to illicit opioids once we don't receive that prescription anymore. How can we be part of the solution to this problem? MAT, or medication-assisted treatment, is really the use of medication in combination with like behavioral counseling to really provide like a whole person approach to treat the substance use disorder and to prevent those related deaths. So let's go back a little bit and talk more about what an addiction actually is, because there's a lot of bias, there's a lot of stigma about addictions in general in society, in our community, and in probably each of us. The most important thing to mention here is that addiction is a disease and that we should treat it as a disease. It's a disease like diabetes or cancer or any other chronic illness. Sometimes there is this notion that people think addiction is a weakness. People can just stop if they just want to. I'm going to go more into that in a little bit and explain why that's not the case. And really, like, addiction can affect anybody of any background. A real important factor is that it changes the brain. It is a chronic disease, and it makes changes to the brain that are long lasting. So even if a person, for example, stops taking the substance, the changes in the brain are not just going to reverse and go back to normal. And that is why it's always, or oftentimes, very hard for people to stay abstinent even after they stopped taking a substance. I wanted to just put this definition on here because I think it is a very important and powerful definition. It is the definition by the American Society of Addiction Medicine. They just adopted this in 2019. And like most medical and professional societies, they define addiction as a chronic medical disease, also as a treatable chronic medical disease. It involves complex interactions among brain circuits, genetics, and the environment and individuals' life experiences. So really important here that it's not just one factor that influences whether somebody has an addiction, but it's really multifaceted. A really hopeful and powerful thing, message is really at the bottom of this, that prevention efforts and treatment approaches are generally as successful as those for other chronic diseases. So I think that is something that really a lot of people are not aware of, but we do need to look at it. It is a chronic disease and it is treatable, and prevention also works. Another important aspect is that addiction is really widespread, but if we look at the numbers, it's just as widespread as heart disease, and it's just a little more widespread as diabetes. If we look at the societal costs of addiction, it's just right up there with the other chronic diseases, as you can see from these numbers. I don't have to read them to you. So again, I really want to drive home the message that it's a disease just like other chronic diseases that we treat when people come to a primary care office or specialty care, like cancer, diabetes, heart disease, multiple sclerosis, really any other chronic medical disease that is out there. I think what's really important here to mention too is oftentimes when people with an addiction, we come up with a treatment plan for them. We might prescribe the medication for them. We have them engage in behavioral health therapy. And then maybe, a month or two down the treatment, we notice the treatment plan didn't work. They come back and they say, well, I had a lapse, I had a relapse, I screwed up, I don't know what happened, I used. Oftentimes, there's this notion in society where we're like, oh my goodness, why do we even give them treatment if they continue to use? And we really judge that hard. However, I want to just compare that to other chronic medical diseases. If somebody with diabetes comes to their provider and gets on a treatment plan, maybe gets on a medication, the provider discusses some lifestyle changes with that person, maybe more exercise, watching the diet more carefully. That person comes back 2 months later and maybe there were the holidays in between and said, you know what, I really screwed up. I had all the food that I wasn't supposed to eat, but it just looked so delicious, I couldn't resist. I'm still taking the medication, but I'm just not doing well in regards to my lifestyle changes. What would the doctor do in that instance? The provider would sit down with the patient and discuss how to change the treatment plan, how to adjust the treatment plan and say, okay, let's try again. Let's maybe make some different changes. Like maybe you need a group of people that support you. Maybe we need to look at other options for you. We would never judge that person as much as we judge people with an addictive disorder that had a relapse. Okay. So really, again, we should look at biological, psychological, and social dimensions when we look at any chronic medical disease. So now I'm going to talk a little bit more about like what addictive disorders does Lamprey treat. So first of all, we are treating opioid use disorder. Opioids can be heroin, fentanyl, morphine, oxycodone, etc., all the other prescription opioids that people know. We also treat alcohol use disorder, which probably people are more familiar with, and which is also a widespread problem that we oftentimes don't really talk about, but it's very relevant today. Opioid use disorder is being treated with the medication buprenorphine, which is the brand name Suboxone, and also with injectable naltrexone, which comes under the brand name Vivitrol. Buprenorphine is a medication that gets administered daily. The person takes that medication daily. Injectable naltrexone is a shot that gets injected every 28 days. For alcohol use disorder, injectable naltrexone, the Vivitrol, is also effective. Suboxone is not a medication for alcohol use disorder, just to be clear on that.
Astrid, can I ask a question?
Of course.
Are you offering methadone or Subutex?
No, we do not offer methadone. Methadone can only be offered in methadone clinics. We don't offer Subutex. It used to be that people would prescribe Subutex to pregnant people, because Subutex, the difference between Subutex and Suboxone is that Subutex has naloxone in with the buprenorphine. Suboxone has naloxone in with the buprenorphine, which kind of prevents people from overdosing in case they use. And we used to think that the naloxone can affect the baby negatively if a person is pregnant, but that actually has been shown to not be the case. So now we even prescribe Suboxone to pregnant people. So we at Lamprey Healthcare do not prescribe Subutex just because of the risk of diversion and also because of the higher risk of overdosing.
So I was under the impression that Subutex was a 1-month injectable form.
Nope, Subutex is also it comes in a film form, just like the Suboxone.
Okay, what am I thinking of the one
You
month?
might think of Sublocade.
Sorry, that was it. Yeah.
Yep, I know they all sound very similar. Sublocade is an injectable form of Suboxone. Unfortunately, we are not prescribing that at Lamprey right now. We really would like to, but the problem is that we would have to store this injection on site. And because it is a controlled substance, we haven't really found a way to do that to be compliant with what we need to be compliant with. But we are looking into that. And if anybody has any suggestions or has any ideas on how to do that, I know that health centers that have an on-site pharmacy, they can do that because they have that capacity to store it there. So yeah, we would really like to, because that would offer an additional treatment plan for people that maybe are not as good about taking a medication every day.
Thank you.
Of course. So how do these medications work? The buprenorphine and the naltrexone, they really bind to the brain's receptors. And because they bind to the brain's opioid receptor, they suppress cravings and urges. It helps to decrease and eliminate withdrawal symptoms. And if somebody tries to use an opioid while they're on Suboxone, it really doesn't have the anticipated effect, like they're not getting that high that they might be looking for. If you can imagine, like if you have, this is the opioid receptor and it is blocked, so if you use something on top of it, it doesn't get through it. So you don't have that effect of the substance. For Vivitrol, it can lead to adverse effects if alcohol is consumed, if it's being prescribed for alcohol use disorder. What we have found is that people that are on Vivitrol and have drank high amounts of alcohol daily, this is also a really good harm reduction medication. Because some people might not have the goal to completely quit drinking, and that's okay if they don't have that goal. But Vivitrol can really help them to reduce the drinking by a lot. So drinking small amounts while on Vivitrol does not really make a person sick or anything. However, if they would try to drink a lot of alcohol, a lot of amount, they might get sick on it. They might start vomiting just because of that, that block that is on that receptor. But again, I want to mention we had really good successes with Vivitrol on people that had like alcohol use disorder for long times, that drank huge amounts every day, and now are down to like 1 or 2 beers a day, which to some of us might not sound like great success, but it's huge success and huge improvement of that person's ability to function and their health. I want to mention that medications, those medications are one of many tools used for patients to enter recovery, and they work best in combination with behavioral health support, peer support, care coordination, and other aspects in their life. Again, looking at the whole person, again, using that example of somebody with diabetes, just putting somebody on medication is probably not going to help them much with their diabetes treatment. Does this treatment actually work? The short answer is yes, it is an evidence-based treatment, which means it has been studied and found to be effective. First of all, it improves patient survival. People are not turning to the street and buying substances off the street and overdosing. It increases engagement and retention in treatment. People are actually able to come to the office and engage in behavioral health treatment, engage with their doctor, engage in other aspects of their health. It decreases illicit substance use and criminal activity related to it, obviously, because they can get it legally prescribed from a doctor. They don't have to turn to those criminal activities. It increases the ability to gain and maintain employment. Obviously, people are able to function. They're able to parent their children. They're able to maintain a job. They're able to work on their relationships. The overall quality of life really is improved. Very important also to mention is that it improves birth outcomes and reduces health complications in pregnancies for mother and the baby. So really, if whenever we have somebody come that is pregnant and is actively using, we try to get them in as fast as possible as we can to really support the health of the mother and the baby. It also contributes to lowering the risk of contracting hepatitis C and HIV because people are not engaging in as many risk-taking behaviors. A few things about how does Lamprey provide this treatment. So we usually start with an intake assessment. The person comes in, or now because of COVID, we have adjusted our the way we provide care by having a lot over telehealth. We have a behavioral health intake, really go into the psychosocial history of a person, the substance use history, looking at is there any trauma in the history of the person that we can help people with processes and engage in therapy with. Then they have an intake with the MAT nurse, which will go over the medical history and also substance use history as it relates to the medication. And if needed, we can provide that person with care coordination for housing, for any other social needs that the person might have. After that, if the person is found to be a good fit for our program, which is an important aspect, sometimes people need a more intensive level of care than what we can provide in an outpatient setting, then we help the person to get connected to that more intensive level of care. Sometimes they go to, for example, an inpatient treatment, and once they finish that, they come back to us, and then we are happy to obviously provide them that outpatient level of care that we can. If they're found to be a good fit, we go ahead with an induction, which happens with the MAT provider and the MAT nurse. From then on, we follow up with a patient very closely with every member of our team. Part of that is behavioral health. We do want people to engage in behavioral health while they're in the MAT program, just so we can address co-occurring mental health disorder and really focus on the whole person. And then once the person is in the program, we really just want to continuously monitor the progress. They have regular visits. It usually starts, if they're on Suboxone, it starts with weekly visits. If people are doing well, if they maintain their recovery, if they start engaging in other supports that they need in their daily life, the frequency of their visits gets less and less. And sometimes we have people come in once a month after they're successful. For Vivitrol, obviously people come in once a month for their Vivitrol injection, but they engage in behavioral health as however we determine the treatment plan for them, whatever their need is.
Astrid, can I ask another question?
Of course.
All right. So what's your percentage of Vivitrol to Suboxone? Just a ballpark number. Is it like 60-40? Is it 70-30?
It's probably at 70-30 right now.
Suboxone being the 70?
Yes.
Okay.
Yep.
And I know this is a question for all MAT programs, but how do you guys handle, when I think about addiction, I don't think about a specific substance. I think about, people's drug of choice just being more, right? So if people start to get a handle on their opioid use, but are testing positive for methamphetamine or other substances, how do you guys handle that? Because I know that's a problem for all programs, but.
Absolutely. That is a very good question. I don't think there is an easy answer to that. We try to adjust the treatment plan and try to give that patient the support that they need to be successful in their recovery. And again, when I'm talking about recovery, I don't mean just the recovery from that one substance, right? We look at every substance that there is. We don't discharge people from our program because they use other substances. We really see if somebody uses, or even if they relapse on the opioid, or if they relapse on any other substance, we see that as a way to show us that the treatment plan that we have currently in place for this person is not working. And it is we need to then adjust the treatment plan for them, or not for them, with them, right? And that may mean that maybe they have to go to an intensive outpatient treatment in addition to what we have to offer them.
Right.
It may mean different things for different people, but that's how we approach it. Okay. I hope that answered your question.
It did. Thank you.
Okay, sure. Again, because we are a primary care office, people that engage in our MAT, they do have to be established Lamprey patients, or they will have to establish care before entering the MAT program. if somebody is not an established patient here, we do have ways to kind of fast track that. We try to get them in as quickly as possible to establish with a provider and then have that intake for MAT. We have the MAT programs at all of our 3 sites. The numbers currently are approximately at like 20 people per site. It fluctuates a lot. Sometimes in the summer, we see the numbers are kind of decreasing. Come fall, come winter, the numbers are usually increasing a little bit. That's kind of like a common theme, I think, among MAT providers from what I hear.
Astrid, do they do groups or they do individual counseling?
They do individual right now. Before last December, we started having a group in Newmarket, an in-person group. It was just trying to get really established, and then COVID hit, so we didn't, we didn't continue with the group. But it's definitely something that we will keep looking at to provide another avenue for people to engage in treatment and in behavioral health. Currently, there are 7 providers that are actively prescribing among all the sites, and we have 1 MAT nurse at each site. The MAT nurse really plays a very important role in our program. It's very nurse-driven. She's kind of the or I shouldn't say she, we have 1 male person too. So the MAT nurse is the person that really coordinates the care for the patients and is the #1 contact person. We actually have more waivered providers at Lamprey Healthcare, which is really helpful in case, people are out, or if we get increased numbers, we have the capacity to grow. And like, I think I mentioned this before, but the MAT team really consists of medical provider, the MAT nurse, the behavioral clinicians, and the care coordinators. I want to talk a little bit about some myth about MAT, just because I know there's a lot of controversial things out there. People believe different things. One of them is just people believe that MAT just trades one addiction for another, because obviously people that are on buprenorphine, on Suboxone, it is a medication that they are dependent on, that we can't just stop, that we have slowly decreased the use, slowly taper people off. So then sometimes people use the argument like, well, it's just another addiction. It's a huge difference, obviously, because it is administered by a medical professional. It is legal. People actually get the chance to start engaging in therapy, start engaging in looking at their life, trying to get their life together. So a combination of medication and behavior therapies is very successful in treating SUDs, and we should really not look at it as treating one addiction for another. Another myth is that MAT increases the risk of overdose in patients, which is absolutely not true, because if it's medically monitored, we prescribe patients just the right amount for buprenorphine, that they do not have withdrawals, that they feel they can function, that they are feeling well. Nobody that is prescribed buprenorphine or Suboxone is being sedated. Sometimes you have the impression, well, they're going to get high off that medication. No, not when it's prescribed. That high comes when people go on the street and buy the substance off the street. So that's really important, that it decreases the risk of overdose in patients. Another one is that providing MAT will only disrupt and hinder a patient's recovery process. And it goes right along with, there isn't any proof that MAT is better than abstinence. So again, this is completely false. Providing MAT will help people enter the recovery process. I want to also mention being on a medication like buprenorphine is not for everyone. It might not be the path to recovery for every person, and that is okay. But it is one avenue that we can, or one option that we have for people, and it can make a tremendous difference, and it can help them enter recovery. Sometimes people come to us, they have tried over and over again without medication, and we're not successful in doing that. And then once they start trying Suboxone, all of a sudden they are able to enter recovery and be successful in their recovery, and start having a job and start being more productive members of society and engaged in their family life and parenting and all these other aspects.
Astrid, another question.
Yeah.
What's the average stay for somebody? The research that I read says about 2 years on average that people will stay in a program like this. Is that your experience as well? Are you shorter, longer?
I can't really speak to this because we have started our program in 2018 in Newmarket, and we just started the one in Raymond and Nashua last year in January. So I can't really say what the average, if it's 2 years or whatever it is. What we know is if somebody used for a long time, let's say we have somebody come to the program that I'm just making this up. Let's say it's a 50-year-old person, right? And that person has used opioids for the last 30 years of their life. Chances are that person will have to be on buprenorphine for quite a while before we are ready to taper them off. It also might be that they will have to be on buprenorphine for the rest of their life. Because it's an individual approach, there is really no set formula to know how long a person will have to be on this. We have very successfully seen people also get off Suboxone again. I have the example, I think it was a woman in her 30s. She had used probably for about 5 or 6 years, started on Suboxone, was on Suboxone for, I think, 1.5 years. And she basically came to us and said, like, I think I'm ready to taper off. So we slowly tapered her off. Again, it's an individual approach. We don't use like a set formula. We look at the person, we look at the person's environment and what they feel comfortable with. And she successfully tapered off and is still in recovery and doing well. So this, there's no real answer on like how long does somebody need to be on the medication. Some people might have to be on it for the rest of their life, especially if they used for a very long time. What's your average involvement with these guys? Like, how long do people actually stay in your program? Do you mean? Is there an average length of treatment for these guys? Somebody comes in 2018 and you're still engaged in the program in 2020 or 21? Yeah, we still have people in the program that started then. Yep. Okay. And is there an average? I don't have that number. I apologize. Sorry. I would have to. That's a good question, though. I should really know that number and I should find that out. Thank you for bringing that up. Sometimes what we also find is like people have the motivation why people come into the program can be quite different, right? Sometimes people come on their own terms. They something happened in their life and they're like, I need to change. I want to make a change in my life. I don't want to be using anymore. Can you help us? Sometimes people come to us because their probation officer might recommend that to them and say, if you don't engage in MAT, that's going to have legal consequences for you. What research really has shown, it doesn't really matter why somebody comes to us and wants to engage in recovery, and people might really be ambivalent at first and be not that much into it. That's maybe not the right way to say it, but they might not really think that that's going to be helpful, but over time that might change. So we should really be open to everybody coming in, no matter what their motivation is to start this, because it quickly changes over time, and we have really seen huge changes in people and their motivation to enter recovery. And if for nothing else, if we are doing harm reduction, then we are doing something because we're preventing people from dying of overdose. I want to just say a few things. I think I only have like 2 more slides about fear and stigma, because I think there's a lot of fear about substance use disorders. Oftentimes people are looked at or shown in the media as being violent or I don't know what. And I think a lot of it has to do with not knowing what to expect, having fear of addressing this problem. And obviously having stigma towards it affects how we approach patients and influence how successful they can be in treatment, because they know they feel if we have stigma towards them. They know this. So really what we try to do is like to see a person for who they are, to avoid hurtful labels and language. I think the next thing is really so important to know, like nobody chooses to become addicted to a substance. People become too addicted to substance for so many different reasons. Sometimes they had traumatic experiences or adverse childhood experience that they were never able to process, that they were never able to talk about, or even sometimes it's not even apparent to them that that has a relation to their substance use. Sometimes people just simply had an accident 10 years ago and were prescribed huge amounts of opioids, and then all of a sudden that prescription was cut off and they weren't really tapered off appropriately and had to turn to the street and buy substances illegally because they didn't want to have withdrawal symptoms. They still wanted to go to work and not be sick. We really believe that everyone deserves a chance to get better and make positive changes in their life. And again, I'm going to go back to the chronic disease model, right? We would give everyone a chance that enters the doctor office and says like, you know, I have diabetes or I have heart disease. Like we would do everything we can to help that person make changes in their life to have better outcomes. By providing MAT, we really have a chance to help them make that change and also offer hope that this is possible, right? And hopefully, and not hopefully, I know we are doing that, we are changing the way the community deals with stigma towards substance use disorders by providing this in this community health center setting, right? It's just a normal treatment like everything else that you can get at Lamprey Healthcare, whether you come here for your prenatal care, whether you come here, you know, because you have a sore throat, or whether you come here because, you know, I don't know, you fell down yesterday and you hurt your foot, to have that looked at. We really want it to be like just one of the other things that we treat here at Lamprey Healthcare. So that's really what I was going to talk about today, and I just want to open it up for other questions or comments or experiences that people might have.
Astrid, how long into the Vivitrol shot are your clients reporting that kind of like cravings or urges to use are increasing?
Mm-hmm.
It's supposed to be 28 days. Are they reporting like day 20, 21 where?
Yeah, sometimes it starts for people a week before. What we do then, it is naltrexone. There's an oral tablet form of naltrexone, like the substance that is in the Vivitrol shot, that we then prescribe to people so that they can take that tablet form each day on top of the shot towards the end of their cycle. Some people don't experience any cravings even towards the end of their cycle, but some people definitely do, and that's why we then prescribe them that oral naltrexone form to have that as an extra cushion.
Nice. And I know this is a stupid question, but do you guys send them home with Narcan as well in case there's a relapse?
Absolutely, absolutely. That is one of the first questions that we ask doing an intake, or even before the intake when we're on the phone and they want to schedule an intake. We make sure that they have Narcan available.
Cool.
Yeah, we distribute Narcan to everyone that wants it, and obviously we can't force people to take it, but we're getting close to forcing them to take it, just in case.
Just in case.
Yeah. And we make sure, like, we periodically still ask them, do you still have Narcan at home? Because they may have used it, or, and we don't ask questions, you know, whether they use it for themselves or somebody else. It doesn't matter to us. We just want them to have it.
Are the clients reporting a lot of stigma in the recovery community as far as like people at meetings telling them they're not really clean or any of those? I'm very familiar with the recovery community, and
I
like
can tell.
they you know, the meetings that I'm familiar with will actually go out of their way to say, you know, the only requirement for membership is a desire to stop using. So
Yeah.
but client
Unfortunately, sorry, I didn't want to.
No, client perception is client perception, and like the receiver is always correct, right?
Right. Unfortunately, sometimes people still report of this, that they experience some bias around this. I also think that it really depends on the meeting. There's a lot of support of MAT in meetings. There are some meetings I know, you know, where more like the old school people go to, that might not believe in MAT. And I think what's good about having people engage in behavioral health too, then we can have, as behavioral health clinicians, we can have a conversation with people around, so what do you say to that? And like, you know, does that impact you so much that you feel like it's not helpful for you to go to that meeting anymore? Or do you feel like you can be assertive about it and maybe share your experience with it so that we can like educate people about it? Very good question though. Yeah.
Any other questions? This is an amazing resource that we have here in the community, and thank you so much, Astrid, for sharing a great presentation to raise awareness to it. How does somebody refer a person to Lamprey? If they had somebody, if they know somebody, or if they're working with somebody who might be in need of services?
So really just kind of calling our phone number as usual and just saying that the person is interested in MAT. And then we have like ways behind the scenes to kind of fast track that and get back to the person.
Okay.
Yeah.
Very good.
Mm-hmm.
Anybody else? No? Okay. Thank you very much. We really appreciate your time and putting a great presentation together.
Yeah, thank you for giving me the opportunity. And if there's
Absolutely.
ever any questions, feel free to reach out to Lamprey. We're more than happy to answer questions that come up in the community, or, you know, specific cases. We're here for treating people with substance use disorders.
Thank you. And thank you, Carrie, for suggesting Astrid join us today. That was great. Okay. So we'll move on the agenda. So because of COVID, we're entering into 2021, and the many events that we usually have planned seem to be getting canceled left and right, or not even being planned at all, or we're trying to maneuver around how to make them happen. But in the absence of that, it's been pointed out that it's a good time to utilize this time in coalition work to go back to our roots and to go back to the assessment of why our coalition is even here, and what things we should be focusing on in the community, and what is of value to our partners, all of you who are on the call today, and then other people in the community. How can we best work together to address the needs of the community? So on the call also is Dr. May Delaney, unless did she jump off? She's right in front of me, okay. She's been our evaluator for, May, how long has it been?
Long time.
Long time. We'll just go with a long time. Long time sounds good. So for anybody who doesn't know, the coalition was formed back in 2000 in reaction, I guess, or response to data taken from Raymond. So UNH, the University of New Hampshire, came and gathered a group of people together and told us about a sample survey of data for our high school students, and that our rates of substance misuse were higher than the state averages of the Youth Risk Behavior Survey. And that's really what got the coalition together, got the people in the community talking, and then 42 people went to that first meeting to talk about that. The second meeting, I think there were like 12 people. So it became clear who was really important to and who was concerned about it. And then the coalition has moved forward from there. They did a teen assessment project survey, which is the same as the Youth Risk Behavior Survey, just not through the CDC. It's more of a, I'll say a private survey that's done with UNH. You get to choose all of your questions. And that was our baseline data for our community. And then we had a lot of focus groups, one-on-one interviews, key informant interviews that really found out what the concerns were in the community, who was concerned, what they were concerned about, and that was the basis of our work moving forward. Now we've done that here and there. We've done surveys annually, pretty much annually, to check in with the community to see where they're at. But this is really a time to go back to our strategic prevention framework, and the first step of that is assessment, and really dive in and find out what the needs are. And it's actually perfect timing because the school district has the Project Aware grant that they're implementing, and they have a leadership committee that's meeting on behavioral health issues at the school level and integrating the community into that. So instead of driving two buses in two different directions, we really want to get on the same bus and just make sure that the community is working in sync with the school on issues, if they're talking about truancy issues, what's contributing to truancy? How is a family or the community impacting that? And how do those things go hand in hand? How does that maybe impact the police department? If that's something that they're seeing an issue with, if students aren't going to school, if they're out, I'm not saying this is happening, just an example. If they're out in the community, maybe they're getting into trouble because they're not in school. What does that look like, and how can we work together to address those things? The marijuana issue that the kids are bringing to our attention, how that's impacting their family life, how that's impacting their friends. If they're telling us that, how can we as adults support them and give them the tools that they need to raise awareness to their friends? So it's really about all of us working together and finding out what is the best way to do that. So the best way to do that is through assessment. So Dr. May Delaney has dedicated, how would you like to phrase this, May? How do we have you for 6 months?
I think, Celeste, you've said it beautifully. That the only thing I would add is the data that we started with is well over a decade old. And even though we've been up to date almost every year, certainly every other year with the Youth Risk Behavior Survey, we need to keep in mind that there's lots of changes that have happened in the area, from leadership within the local administration, and I don't just mean government, school, the businesses that have come and gone in Raymond. I mean, Celeste and I have talked about this, and on a personal level, I've had family that's lived in Raymond, and I've seen huge changes in the composition of the town, population-wise, cultural changes, and most of this is for the positive. But unfortunately, the statistics are still showing that Raymond's youth substance misuse issue is still above the norm, and that can impact the community as a whole. So Celeste, we had originally planned a different project for my 6 months that I'm not at Worcester State. I'm actually on sabbatical, so I'm free to do research. But COVID has interfered with all of our plans. So what we had originally planned is not going to work out. And so I agree with Celeste. I think it's a great time, given that we can't necessarily have focus groups. We can't do the Youth Risk Behavior Survey at this current moment. We have to postpone things because of our pandemic. And so it's a great opportunity for us to come together and re-strategize what it is the community needs and wants. Does that sound right, Celeste?
Yes. Perfect. Does anybody have any questions or thoughts on that? Because this will be a pretty in-depth conversation, an in-depth process. Given that we're on Zoom right now, it's going to be very complex. It's going to be so much fun. But it's exciting to look forward and engage the community at a different level, because we haven't really reached out. All of our parents are going to be completely new parents from when we started, obviously, because their children have grown up. We might have some parents who were children when this coalition first started. I can personally attest to knowing too many parents in this community who have lost children to the opioid epidemic. Far too many parents who are struggling to raise children because of the opioid epidemic. When the coalition first started, just to give you an idea of where we were, the students who we surveyed at that time in grades 7 to 12 are now people who are 32 to 39 years old. They're the ones who were most dramatically impacted by the opioid epidemic. And I think we're going to learn a lot about that when we go into the assessment phase. We know there are grandparents raising grandchildren at the elementary school level. Those people are the ones who are impacted by the opioid epidemic. Those children are the ones who are impacted by it. So it's going to be very informative. I am excited about it to know what our community needs and how we can best be utilizing our services moving forward. So hopefully everybody will be on board and part of the process in some way, because obviously the more people who are engaged, the more successful it will be. I know Jess is on the call, Jess Karen from the school. I don't know if you want to add anything to that, Jess, or you have any thoughts?
No, I mean, I think we're also sort of early on in our planning, and so I just think it's exciting to think about, how we can really expand the scope of the work and by strengthening this partnership with the coalition. And so I think it'll be really interesting to figure out which data points we'll each look at year to year to sort of track that progress. So I look forward to partnering with you on that, just to make sure that we're in that alignment together and sort of on that same bus. So, we're obviously more than willing to share, any of our data or what we've learned so far. It was a pretty crude kind of data walk that we took so far as a DCLT. And so I just also validate that this is tough work to do through Zoom. But please just let me know how we can really intentionally use some of that meeting time to make sure that the DCLT is clear on what the coalition is working on and vice versa.
Questions or thoughts from anybody? No? Okay. Another part of that, so as a coalition, we have a board of directors because the coalition is a nonprofit organization, so we have to have a governing body. And they're looking at the strategic focus for them moving forward. So where's the nonprofit going? Basically the funding for the coalition and how we're funding it. And there are a few grant opportunities that we are hoping are going to be released. Because of COVID, they're typically released by now, but they haven't been announced yet that we want to apply for. And so we've been looking at some of our language, what our language is, and we've had the same tagline of promoting positive, healthy choices for youth since we started. And it was brought to our attention that what are positive choices? What are we talking? Are we talking about how people eat, their exercise, or should we be a little bit more specific in what we're saying? And should that be promoting safe, healthy, drug-free choices for youth? And that's gone back and forth, bounced around a few times. And I said that I would take it to this group to see if anybody had any opinions or thoughts on if we should keep it the way it is or if we should adjust the wording. Again, it's been promoting positive, healthy choices for youth. And it would be, or should we change that or talk about the difference of making it promoting safe, healthy, drug-free choices for youth? It's hard to do on Zoom. I know it's hard to have opinions or a conversation. But I said I would ask all of you and see if anybody had a thought. Stephen?
Okay, so I think I was on the board of directors back then when we came up with the tagline, and I was a strong proponent for emphasizing positive youth development, which is a philosophy that says basically if kids are healthy and happy, they're not going to turn to substances at all. So that the best way that we can reduce substance within our community, reduce substance use, is to provide our young people with appropriate activities that are going to fulfill them rather than chasing them once they've started to use substances. So I personally remain strongly in favor of keeping the emphasis on the healthy choices that our young people can make. And, obviously I've been part of the coalition for a long time and support what we're doing in terms of prevention. But I think the message, if we can keep the message positive, that goes a long ways.
Thank you, Stephen.
I was curious, Celeste, if we have any feedback from the youth that are involved.
Great question. So Christine can put that on the agenda for the meeting next week.
I definitely will. I definitely will. My input is I do agree with Stephen in keeping it the same. And the reason that I say that is because when I'm working with the kids right now, regardless if it's COVID or not, we're still talking about self-care. We're still talking about exercise, which to me are all positive, healthy choices. We're not just restricting it to just drug and alcohol use. It's the whole gamut for the kids and promoting that they do healthy actions. So that's just my 2 cents and my feedback on it as well. But I will add that to the agenda next week.
Anybody else?
Celeste, I think if I recall correctly, the reason why the wording was generic is because the focus wasn't just substance misuse, it was also on suicide at the time. And that, I know that's something that I have not looked at in the very long time, that, but that might be something the community's interested in. I think that's the important of working on this assessment, seeing what direction folks want the coalition to go in. And when I say folks, I'm including everyone from the youth to the schools to mental health, the medical community, police, everyone. What is it they want from the community? Because that might help with the language, because while I agree with everyone, it doesn't matter what I think. There's the other side of it where maybe there needs to be some specificity so there's clarity. And that's my only 2 cents.
Very good. Thank you. So obviously this is not a decision that's being made today. It was just bring it to you for some input and some conversation. So I appreciate the feedback. And again, it's a process. So at the board level, it's been a process doing strategic planning during COVID. It's not fun, so it is a challenge. But I know Jess is going through the same challenge with her grant. It's just a challenge. So, and as May said, a lot of this will come out as we're engaging the community in the process. So that's exciting. Okay, so that's more to come on that. More information on that. The next thing on the agenda, if anyone's following along, is a youth action update from Christine.
Hello, good morning. So with Youth Action, we had a couple weeks off because of the holiday, which was nice. We all enjoyed it. The kids had a great vacation, even though they weren't able to see as many family and friends as they would have liked. They loved still being with their family, which was great to hear when we talked with them. Our major focus for about 3 or 4 weeks at this point is the baby drive that we have going on. The baby drive supply drive does end tomorrow. If anybody has a donation of a pacifier or some baby cream or a package of diapers, I'd love to meet up with you, or we could meet at the town office and do an exchange outside of the building. And I can pick them up because next week I'll be going to the church and dropping everything off. We've got the kids have been very active with their families and their networks and trying to get donations for the baby supplies drive for New Life Church. So we're very excited about how that's been going. We've spent quite some time on the marijuana warrant articles for about a couple of months, gathering signatures and talking about the process of how it works, where it goes, what's going to be happening in March. I already mentioned that we had a great conversation at the high school level yesterday, so that was amazing to hear their points of view as well as their interpretations of what I was reading and sharing with them. And then again, like I mentioned, self-care and exercise is really big. We were on a Zoom yesterday with the high school kids, and we were talking, and they immediately let me know they had to go because they had another Zoom to jump on too. So it's important that we talk about that self-care and exercise because they're still trying to juggle a bunch of things. And if they're not taking care of themselves, then that's when we start to see them possibly regressing into some of that negative behavior that we don't want them to be part of. So I was very cognizant of that, letting them get back to their class and whatnot. And next week's is finals for them. So they're a little nervous about that, but we're still going to try to meet on Wednesday if it still will work for them, because that's our meeting day. But the RAM time that we meet is their study time. So we're going to try to still get together next week. But that's what I have for an update.
Very good. Thank you. Does anybody have any questions for Christine? No? Okay. Very good. Just to emphasize that out in the community talking, people are overwhelmed. Parents, again, grandparents, I'll say, kids, it's a lot for people to be going through. The teaching staff, I'm sure the staff, hats go off to the school and all the work that they've been doing, trying to keep everything moving forward and some normalcy in all of this. It's not an easy task. And the after school program that stepped in to help with the students who need assistance when the school's gone remote. So a lot of people have worked really, really hard, and thank you to everybody who's part of that. That's a big thing. The next thing on the agenda is our gala that was scheduled for March 6th. You're the first to know the decision was made, yes, just this week to cancel the gala, for obvious reasons. And we're going to be looking into, we have a few people working on a idea of doing baskets or an online auction. If anyone's interested or has some knowledge they want to share, that would be fantastic, and we would welcome it, because we're really just starting from scratch on where we want to go with it. But we had a lot of donations for the gala last year, and we obviously want to use them as best we can. If it's a basket raffle or an online auction or something like that. So more information to come on that. If you're interested. Yes, Stephen?
I have some experience doing an online auction for other organizations, so if you need some help with that, let me know.
We need some help with that, so we'll be in touch. Thank you very much. Okay. The next thing is disc golf update. So obviously there's snow on the ground and it's freezing cold, and however, Pat's on the call. I'm told people still go outside and play disc golf in this. The exciting news is Pat had ordered the baskets for us a few months ago, and they're now in. So they've been delivered and they look awesome, but now we can't put them in the ground. So that's the update. I just want to make sure everybody's aware that the process is in motion. We have the supplies needed to complete the course. We have a Boy Scout who's working on the benches that he's going to design them and put them together, get all the materials donated. So it's a real community project that we're really excited about. I don't know if anybody has any questions, or Pat, you want to add anything to that?
No, I mean, it's just a relief to know the baskets are in. I know they've been in transit for a very long time, so now that they're here, I think it's going to be pretty smooth sailing to be ready to start once the real season begins and the snow's thawed and the ground's ready for us to put the tee pads and everything in. So it was going to be great.
Obviously, I look forward to a great grand opening ribbon cutting of that project. The family that we're working with of Cameron Bear have just done an amazing job helping to raise funds and get things in order. So we're really excited. They're very well connected to the community and resources. So they really took the lead on this project, which is exciting. So I wanted to make sure I skipped over it on the agenda, but tomorrow is the SAM New Hampshire Summit, the virtual summit, if anybody's interested in attending that. It's time to stand up to big marijuana to keep New Hampshire a safe place to live, work, and play. They have some great speakers lined up. It's a 3-hour, 10 a.m. to 1 p.m. virtual seminar. Dr. Kevin Sabet is the lead speaker. He spoke at our prevention summit 4 years ago, I think, 3 or 4 years ago. That's on our YouTube page. He really frames marijuana in a different point of view. Not saying it's bad, not saying it's good, just saying be aware of what that's going to look like for your community. And it should be a really great summit. It's free. The link was on the email that I sent out yesterday if you're interested in signing up. The other thing, we were featured on the news Monday night, I think, with the school. The school district did a press release on all of the great work they're doing for Project Aware for our students' mental health, well-being, and behavioral health services. I think it was a very nice story. I don't know if Jess or Tina want to say anything, highlighting the partnerships of the community. It's on our YouTube page. Hello.
I would like to say something, but I'll let Jessica say more. I was thinking as I was listening and talking, hearing you talk, is that although it's been such a challenging time for everyone all around, and we feel like many of us, like we're just in survival mode all the time. It doesn't matter who you are, if you're parents, grandparents, teachers, everyone. I feel really good about one thing, and that is that because of Raymond Coalition for Youth and because of the work of Jessica, Karen, and Project Aware and the interplay between that, and all the different folks that come together in a way that's unique, I think, compared to other communities. We are moving ahead in these areas and protecting, you know, mental health and prevention of mental health issues or other types of issues. And I think that that's a much bigger accomplishment than anyone could ever realize, that we can actually improve and move ahead and strengthen what we do in anything at a time like this. And so I just want to thank Jessica and you, Celeste, and everyone that's involved for working together and not just putting it all by the wayside like it would naturally, you know, psychologically. I think we have very little bandwidth right now for a lot of things. And I really want to thank you for keeping it on the front burner, all of you. And having Jessica come on the scene since March has just been fantastic. So I will let her talk about the interview and what happened. But it's on the map there. You know.
Yeah, I'll be infamous any day now. No, I think, you know, one of the things that really strikes me in terms of just joining this community and kind of being a newbie in the state of New Hampshire is really just about how welcoming these community partners have been. And so the success of this project is not really because I've been here, but it really is the willingness of the coalition and Seacoast Mental Health and other community partners to just meet with us and try to work these things out and be persistent. You know, Project Aware is in a few other school districts, and one of the things that is currently making Raymond unique is how engaged our community is and how well attended our district community leadership team meeting is. So for me, this has been a really just amazing experience to be able to collaborate, you know, interagency, interorganization in such a way, and really be able to see that when we all own a little piece of it, we can accomplish a lot more in a smaller sort of frame of time. And my hope is that by doing this and spreading the responsibility across multiple partners will really help us sustain this work in the years to come. And I'll just say one, you know, funny kind of note about, you know, for me, I think in such a chaotic time, it's important to communicate out what we're doing. So I wrote this, you know, kind of dinky press release also just so that it wasn't about COVID. And I think one of the great things is that a parent read it. And she asked me more questions, and now as a result, that parent is on our DCLT. So, you know, for me, that's the coolest part of it. It's not necessarily the fact that WMUR read it, but it's really the fact that that parent read it and reached out, and now we have another great partner on our DCLT. So this is just, it's been hard work. I think it's hard work for everyone right now, but I think sometimes when you sit and reflect back on what's been accomplished so far, that feels like a nice activity. So I can't be more thankful to Celeste and the coalition and Seacoast and the ways that we've been able to partner in a time that it's just been so necessary. Like, I feel so relieved that we have these things in place for our students right now. So.
And I will add that I had been joking with some of the administrators. I said I will give my right arm for a story that has nothing to do really with COVID-19. Not that everything has something to do with it, but like it's not about that, you know. And so Jessica scored and pulled up the story. And I want to reiterate that if anyone has a story that has nothing to do with COVID-19, send it my way. We'll get another one going. You know. So thank you.
Very good. And I love the fact that both of you tied in that this is really about everybody, everybody on this phone call. Everybody contributes to the success of what's getting done. And I think that was highlighted in the MUR piece, that it was really about community working together, which is what made the story even greater, that it's just not one organization or one department. It's working together that's happening, making it happen. So thank you all for that. The last thing I want to do is announce who our speaker is next week and next month, which is a little disturbing to me, and Pamela's on the call. I went to her afterwards. We have a great partnership with Agent John Delina of the DEA, Drug Enforcement Agency, and he called me on one of these days this week, and he said that he needs prevention's help. He had contacted us and another organization, another prevention organization in the state. Apparently he had a meeting with the governor, the governor's drug czar, I guess you would call him, Dave Mara, state police. A lot of law enforcement are involved in this. Is he Commissioner Quinn now? Of the safety, who was involved. and they were talking about methamphetamine in the state of New Hampshire and how serious it is, and that we really need to put some prevention effort into this. And I, of course, have on my list to call Chief LaBelle and ask if this is something that I said, we don't have that problem in Raymond. I don't know if we have that problem in Raymond or not, so I shouldn't have said that. His response to me was, I'm calling you, aren't I? So that's very scary. It's very scary for many, many reasons. Astrid obviously gave an amazing presentation on medication-assisted treatment for opioid abuse. There really is no medication treatment for methamphetamine abuse. It's really about preventing that and preventing somebody from even getting to that. And as we approach the opioid epidemic, we consistently said, nobody sets out to use opioids. Well, nobody sets out to start using methamphetamines. It starts somewhere. It starts with alcohol, it starts with marijuana. And that's really gonna have to be our conversation around this and raising awareness. So Agent Delina will be our speaker next month on February 11th. He really wants to get the word out there that this is a concern in the state of New Hampshire. Even if it's not right here in our community right now, it's something that if it's around us, we need to be concerned about it, and we need to be having a conversation about it. I don't know if Lieutenant Shevlin or Chief LaBelle want to add to that, or if you'd prefer to have a conversation offline, or.
I think we'll have a conversation offline on that, Celeste.
Okay, very good.
Thank you.
Thank you. But I just wanted to make sure everybody knew that was coming up next month. We'll learn more about that, and you may hear more about it in the news. Again, it's something that he was very concerned about, and he wanted to get people talking about to start prevention. So does anybody have anything else they would like to add? Any happy that wasn't COVID, Tina, but it wasn't happy. Have a good story to share with us before we leave? No, just done. Okay. Well, thank you all for taking some time out of your very busy morning to join us and be a part of the coalition. I think it was a good meeting. I hope you found it to be useful and you found some information today. Thank you, Carrie, again for bringing Astrid in to speak to us about the services at Lamprey Healthcare. And I hope you all have a great day.